All right, let's jump right into it. Today, we're going to simulate a general surgery board exam, a viva. We'll be tackling a classic biliary case, taking it all the way from the emergency department to a complex complication. I'll be your candidate, and together we'll break down the right answers and, more importantly, the thinking behind them. Let's get started.
So, here's our roadmap. Our mock exam is broken down into 5 parts. We'll kick things off with the initial presentation, move into the clinical workup, and then, this is where it gets interesting, we'll hit a serious post-op complication. After that, we'll figure out exactly what went wrong, and finally, we'll lay out the definitive life-saving management plan. This whole thing is set up to feel just like a real exam station. Okay, the scene is set. I'm the candidate, you're watching over my shoulder, and the examiner is about to drop the case on us. This is that moment in a real exam where you just need to take a deep breath, listen really carefully, and start building your answer in your head before you even open your mouth. And there it is, our opening gambit. Seems pretty standard, right? But this kind of presentation can hide some really serious problems. Now pay close attention to the question. How will you approach the patient? This isn't a trick, it's a test of your basic, safe, clinical instincts. The examiner wants to see a system, a safe process, long before you start throwing out diagnoses.
So, as the candidate, my first words need to build confidence. I'd say something like, "Thank you." I'd start with a systematic approach. First, I'll introduce myself and confirm the patient's identity. Then, I'll take a focused history and perform a thorough physical exam. With that information, I'll create a differential diagnosis and then order the appropriate investigations to narrow it down. You see? Laying out that structure right away tells the examiner you're safe, you're organized, and you're not going to miss a step.
Okay, so we've laid out the framework. Now, the examiner is going to want me to fill in the blanks. Let's dive into the specifics of how we're going to build this clinical picture, one piece of evidence at a time. This is really where the details matter. When it comes to history, I'm going to hammer down on the pain. When did it start? What's it like? Does it go anywhere? Maybe to the right shoulder? That's a classic sign. I definitely ask about fevers. That points to infection. And I'd screen for gallstone risk factors, like a big recent weight loss. But here's a pro move. I'd also ask about chest pain. You've got to rule out a heart attack masquerading as abdominal pain. It shows you're thinking broadly and safely. For the physical exam, I'm starting with the B6, vital signs. Is there a fever? Is the heart rate high? These are red flags for sepsis. Then a quick look at the eyes for any yellowing or jaundice. And of course, the main event is the abdominal exam. I'm looking for old surgery scars, and then I'm going to carefully palpate, zeroing in on that right upper quadrant to see if I can get a positive Murphy sign, a textbook indicator for an inflamed gallbladder. And here it comes, the next logical step from the examiner. We haven't even ordered a single test yet, but they want to know what's going through my head. This is a pure test of clinical reasoning. My answer has to be structured, with the most likely thing first. So I'd say, okay, based on this classic picture, my #1 diagnosis is acute cholecystitis. It just fits perfectly. But I'm also worried about acute cholangitis, especially if he looks jaundiced. It could also be simple biliary colic, if there are no signs of infection, or even acute pancreatitis, since gallstones are a major cause. And we can't forget the really nasty stuff, like a perforated ulcer. Lastly, you always have to consider non-abdominal causes, like a right lower lobe pneumonia, which can refer pain to the abdomen.
Okay, the examiner likes my thought process. Now they're pushing me for a concrete plan. How are we going to prove it? My answer here needs to be logical, targeted, and, not wasteful. I break it down into labs and imaging. For blood work, I'm ordering a CBC to look for infection, liver function test to check for a blocked bile duct, amylase and lipase to rule out pancreatitis, and a CRP, which is a good marker for inflammation. For imaging, the first line, best test is an abdominal ultrasound. It's quick, it's safe, and it's fantastic for seeing gallstones and signs of cholecystitis. I'd only think about something fancier like an MRCP or a CT if the ultrasound was a bit of a question mark. Let's say the ultrasound confirms it, acute cholecystitis. The examiner now wants a management plan. I'd be clear and concise. The patient needs to be admitted. We'll make him nil by mouth, get an IV in for fluids and antibiotics, and give him good pain relief. We'll also start DVT prophylaxis. Once he's stable, the definitive treatment is to take the gallbladder out, so I'll consent him for a laparoscopic cholecystectomy. Okay, so far, pretty straightforward stuff. But this is a consultant-level exam, right? They're always going to test you on complications. This is where things get tough, and where the real points are scored. Let's see how the examiner throws us a curveball. There it is. The examiner gives us two key words: difficult surgery. That's a huge red flag. Difficult could mean anything: tons of inflammation, weird anatomy, bleeding. But whatever the reason, that phrase should immediately make you think, maybe something got injured. And the fact that he was sent home sets the stage perfectly for a delayed comeback.
This timeline is absolutely crucial. The patient gets worse after leaving the hospital. You see this pattern: a difficult surgery, a few good days, then a crash with pain, fever, and now jaundice, and your mind should be screaming bile duct injury. It's a classic textbook presentation.
And there's the question that changes everything. The whole clinical picture is different now. My nice, tidy differential from the beginning, it's basically useless. I need a brand new post-operative differential for this very sick patient. This is a make or break moment in the viva. The examiner is testing my ability to handle a disaster. My whole approach now has to be calm, systematic, and laser-focused on patient safety. Let's walk through how we figure this out. My answer has to be sharp and direct. I'd say, given the history of a difficult cholecystectomy followed by this triad of pain, fever, and jaundice, my number one suspicion, by a mile, is major iatrogenic bile duct injury. Other things on the list would be a retained stone in the bile duct, a simple leak from the cystic duct stump, or maybe an abdominal abscess. A biliary stricture is possible, but it usually shows up much later. And boom, the examiner gives us the money shot from the MRCP, the best scan for looking at the bile ducts. This finding is a smoking gun. Dilated intrahepatic radicals with a cutoff sign means the plumbing inside the liver is all backed up and swollen because there's a complete blockage right at the common hepatic duct. It's like a dam has been built where there shouldn't be one. Let's be crystal clear about what this means. This isn't a small tear or a minor leak. This is a complete disconnection of the main drainage pipe from the liver. The liver is making bile, but it has absolutely nowhere to go. That's what causes the jaundice, and that stagnant bile gets infected, leading to life-threatening sepsis. This is a 5-alarm surgical fire.
So, we know the problem. Now comes the most important part of the whole exam. What are you going to do about it? And I'll tell you the biggest pitfall, the thing that will fail you instantly, is saying you'd rush this patient back to the operating room. That's the wrong move. The right answer is a staged, calm, multidisciplinary approach. My management plan would have 5 critical steps, and the order is everything. 1, resuscitate. ABCs, IV fluids, get the patient stable. 2, control the sepsis. That means broad-spectrum IV antibiotics right away. 3, and this is key, decompress the system. We need to get a drain into the liver, usually with interventional radiology, to let that backed-up bile out. This buys us precious time. 4, refer. You immediately get on the phone to a specialized hepatobiliary center. This is not a case for a general hospital. And finally, step 5, the definitive repair. That's a huge operation called a Roux-en-Y hepatoduodenostomy, and it's best done weeks, maybe even months later by an expert, once all the initial inflammation has settled down.
So what are the big takeaways here? First, always have a high index of suspicion for a bile duct injury after a difficult cholecystectomy. The single biggest mistake is to rush a septic, unstable patient back to the OR. The mantra is simple: control the sepsis, drain the bile, and refer to an expert. That is the safe, correct, and pass the exam answer. And just to leave you with a final brain teaser, imagine the examiner asks this. Recognizing the injury the second it happens completely changes the game. If you see bile coming from where it shouldn't be, you have to stop everything. You need to figure out what's going on, maybe do an on-table x-ray with dye to map out the ducts, and most importantly, have the humility to call for senior help right then and there. It's a tough situation, but it really highlights why this topic is so incredibly important for every single general surgeon.